Oh, okay.
Okay, yeah.
Um,
Yes, any questions?
this is pertaining to the exam. Like, should we know about polynephritis and whatnot, or just like hemodialysis, peritoneal dialysis, or just like what we did this semester?
Yeah, because the AGN, it's part of the adult health too. So it's a foundation for, to understand the acute diseases like hemodialysis and chronic like CKD and ESRD. So it's the foundation for that. It's the basis. So it's being
So
covered
we
in
should
adult
have
health
an
too.
idea of it. Okay.
Yeah, yeah. I mean, I'm not going to test you on specific like questions on the AGN or on content that being covered in other courses, but just make sure that the case studies here, they do cover the acute illness and the critical care, aspects of the disease. So the hemodialysis, ESRD and peritoneal dialysis, that's most of the questions be around these kind of two content areas. So the this case study, it's a patient with these, can read the vital signs with hypertension, and we constantly been saying that the renal disease result in or cause the increased blood pressure and vice versa. Same thing is that high blood pressure may destroy the kidneys and result in a chronic kidney disease or ESRD. So the patient on with the CHF, patient, past medical history, in hypertension, obesity, and then the patient on these medications, lisinopril, which is a and carvedilol and digoxin. Physical exam, morbid obesity, the chest, rails, both bases or both lungs in the base, edema, one leg more swollen than the other, and no cardiovascular, like no murmurs, no gallops. Now, the some of the concepts here that we are going to review, like hypertension increases myocardial workload and work, and more workload to the heart on the heart, or more cardiac workload requires more oxygen consumption. So more oxygen consumption will lead to more ischemia, and more ischemia will lead to less um, like healthy heart, which would result in a um, unhealthy heart or diseased heart, which is a CHF in this case. So which medication is missing from the patient's treatment that would lower the risk for, the patient's risk of death from CHF? The medication that is going to be um, very effective and that would prevent the fluid overload, which is the
Furosemide? Please, yeah,
it's
please.
actually it's a mineralocorticoid receptor antagonist. And this drug is different from the furosemide because it's a hormone-like medication. It's a mineralocorticoid receptor antagonist, like a steroid, like which is spironolactone, aldactone. They are superior for lowering mortality in patients with CHF. So if we think of mortality in patients with CHF, the one that's going to lower it more will be spironolactone and not furosemide. The CCBs, for example, calcium channel blockers, they can lower the blood pressure, but they will do nothing for mortality benefit and CHF. So all of this is based on the evidence-based practice. That's what's shown that the spironolactone is the most effective drug to um, have a superior effect for lowering the mortality rate in patients with CHF. chest X-ray, enlarged heart, cardiomegaly, um, auto-sat 92%, ABGs. What do you think? ABG is 7.49 pH, PaCO2 230, and we didn't have a bicarb, but what do you think? It's alkalosis or acidosis? 7.49. It's
Alkalosis.
alkalosis. PaCO2 230. It's alkalosis too, right? So this is a respiratory alkalosis, even without looking at the bicarb. We cannot predict the compensation, but we can conclude that this is a respiratory alkalosis without with undefined any compensation because we have no clue about the bicarb, the bicarb value. Patient's BON is 12 and creatinine 0.8, so patient's bicarb is slightly, it's okay within range, both. So the site of action, this is more of the patho or farm question about the furosemide and where's the exact location or site of furosemide latex action on in the kidneys, the tubules. So it's actually it's called, some would call it a and it's the according to the classification or group name for the drug of furosemide, it's usually called high ceiling diuretics. Others call it the loop diuretic. So it's this drug is as if the exact site is B, the thick ascending limb of loop of Henel. That's exactly where this drug is going to work on the kidneys. So the in which that furosemide on that specific site of the kidneys and the loop, the high ceiling, the ascending limb of the loop, in which that whereas the 25% of the sodium is absorbed at that nephron. And you know that the furosemide as well, also it's it's a potassium losing, so it's going to fail to reabsorb the potassium. So that's why the potassium won't be lost in the urine. So we have a potassium losing diuretic, which is furosemide. The then there's an orders for this patient to have an echo and then Chem7 and troponin. And we said that the Chem7 is equivalent to the BMP, basic metabolic panel. The CT was done, and CT shows no clotting or no thrombosis. There is no any clot or thrombosis, or so that the PE, we're trying to do the CT for this patient to rule out the PE, the pulmonary embolism. Given that the CT came back negative, then the PE, pulmonary embolism, is excluded. And then we are looking at the BMP or AMP, the BMP, which is the natriuretic peptide, which is usually produced by the atrial stretching when there is a cardiac cardiomegaly or cardiac congestion, and the expansion and the stretching of the atria that will result in fluid overload and increased BMP in response to the stretching of the atria. The BUN to creatinine ratio. So we have BUN 37, creatinine 2.5. And when looking at the ratio, the ratio is critical because the ratio we can predict or rule out, we can, it will help on differential diagnoses as well. So the BUN to creatinine ratio, when it's over 20 to 1, like 20 BUN to 1 creatinine, this is most likely is going to be pre-renal azotemia due to decreased perfusion. So this would be we can predict, we can say that this is a prerenal azotemia. And we know that azotemia, it's a sign of kidney failure. It's, it's the accumulation of the bun and the creatinine. And but this one specifically is a prerenal. Now, when it's less than 15 to 1, so 20 is more than 20 to 1, it's prerenal azotemia. But when it's less than 15 to 1, then it's intrarenal acute kidney injury, AKI. Or, in other words, it's the acute tubular necrosis, ATN. So we have two numbers here in which that we can, which is bond to creatinine ratio, we can predict the kidney dysfunction. If that's prerenal due to decreased perfusion, or intrarenal, which is a tubular necrosis. So questions here. The most likely etiology of the patient, because this patient was presented with dyspnea on presentation, when the patient presented to the ER. So what could be the etiology or cause for this dyspnea for this patient to be presented in the ER or to the ER with dyspnea?
Professor, can you repeat that question again?
Can you read the question right there on the screen projected? I'm sharing with you the screen. Can you see my screen?
Oh, yes, I do. I thought you
Yeah.
was asking
So
a
it's the
different
first
question.
question in the middle of the, the center of the page or that screen. What was the most likely etiology of the patient's dyspnea on presentation? So the most
Is it
likely
C?
etiology is going to be hypertension. The hypertension, so because the bond to creatinine ratio, they later became clearly 20 to 1 with low urine sodium level and high urine osmolarity. It becomes clear that this is a renal, or I'm sorry, pre-renal azotemia from the over-diuresis. Patient has over-diuresis, so this is a pre-renal azotemia. So the contrast media are the most dangerous in these patients with decreased renal perfusion. So patients with decreased renal perfusion and with any renal dysfunction, high bun, high creatinine, we should attempt to exclude and not to use contrast media for these patients, because contrast media is going to be detrimental to the kidney function.
I think personally, I don't know if anyone else is having this trouble, but trying to understand the bun and creatinine in relation to pre-renal, intrarenal, and post-renal.
Mm-hmm.
I think I'm having a very hard time with that. I don't know if anyone else is.
So I don't. I think we have the numbers. Previous slide, I believe. Like you have the bond 37, creatinine 2.5. You have to figure out the ratio, bond to creatinine ratio. So it's
I'm gonna go ahead and double check. Maybe I missed something.
Yeah. So you look at the ratio, you find that it's higher than higher than 20 to 1. For example, if you have bond of 40 and then of the creatinine 2.0, for example, that's higher than 20 to 1. So the ratio is higher than 20 to 1, then it's pre-renal, but when it's less than 15 to 1, then it's intrarenal. I know that this is one of the difficult concepts, but I don't expect me to provide you with the questions pertains to that, because this is a little advanced. in mid-surge. But given that this is adult L3, and then we have to include some CCRN, which is critical care nursing concepts, then this is part of it. So in terms of changes, what should be changed in chronic medications? So we went over the contrast media. We said that this is very detrimental to the kidneys because that's going to lead to dysfunctions. And um,
Are ARBs renal toxic? Isn't that the one that should be changed? Or
the sorry,
I guess continuous spirolytes?
therapy. Sorry. Yes. So B, digoxin actually, DIG. So the DIG and spironolactone, they have no effect in the diastolic dysfunction. So there is no point of that we add the ARBs. So to the ACE inhibitor. So yeah, ARBs should not be, which is we will stop digoxin actually here. So we need to have the patient's blood pressure controlled, which will avoid the decompensated heart failure for this patient. So decompensation requires that we have to control blood pressure. So the digoxin and the spironolactone, they have no benefit in diastolic dysfunction. So the beta blockers and ACE inhibitors, they are and calcium channel blockers, all of these are very effective for patients with compensated heart failure. So the answer to this one is we can stop the digoxin. So patient, second one is acute renal failure, which is rhabdomyolysis. One of the obvious or clear symptoms, which is the dark urine. And muscle pain. So the dark urine color that's from the release of the myoglobin, myoglobin in the urine that makes change the color of the urine, and then the muscle pain. That's also another sign of rhabdomyolysis and the muscular dysfunction or destruction of the muscles, which is a sign of rhabdomyolysis. The most likely cause of death in patients with a rhabdomyolysis or this scenario is always going to be the hyperkalemia. The single most important fact about the rhabdomyolysis is knowing that the hyperkalemia can lead to death, especially with severe hyperkalemia. The more lab work will be done, including urinalysis and other lab work. So the rhabdomyolysis, it's a condition where timing is essential in terms of that we have to work fast intervention should be implemented, and we have to make sure that we can exclude or treat hyperkalemia immediately, because that can lead to the cardiac toxicity, and can lead to death due to this life-threatening dysrhythmias. And we can tell from the EKG right away. So why do we give patients calcium to protect the heart? And if you look at the answer here, it will raise which is kind of like EMP or pathophysiology question, but it will raise the threshold for depolarization. The calcium makes it hard, which is C, makes it hard for the neural tissue to depolarize. So that's a good thing for the myocardium to depolarize, and that can lead to arrhythmia, which is dysrhythmia. So we refer to this as sometimes as membrane stabilization to depolarize neural and muscle tissue and become more positive until the threshold. So this is more of again, pathophysiology kind of question, but the answer is to raise the threshold for depolarization. Now, the high calcium and low calcium, that's why we give calcium to patients to protect the heart. In this case, is that the high calcium, when you increase the calcium, you make it harder and difficult for the heart to depolarize. Low calcium, it much become like easier for the heart to depolarize. So we want to come to make it harder for the heart to depolarize. That's why we give calcium. So just remember that high calcium, hard depolarization, or difficult to depolarize, which is more safer for the heart. So the hyperphosphatemia. Now, patient has a high phosphate. Now, the mechanism of hyperphosphatemia, that's due to the because that's going to be released because rhabdomyolysis. Remember that it's a destruction of the muscle tissues and muscular cells are going to release the myoglobin and also phosphate. So the release from the muscle will be the more the phosphate. So that's why there is hyperphosphatemia. So the majority of the phosphate inside the muscle and inside the cells. So destruction or destroyed cells and muscle release phosphate and potassium and bind to calcium. The mannitol, the idea of mannitol is to decrease the duration of contact of myoglobin on the kidney tubules. So the mannitol as a treatment that will be like, is going to decrease the duration of contact of myoglobin with the kidney tubules. So that will be more protective if you add mannitol to treat this patient with rhabdomyolysis. The bicarb, why would you give bicarb to this patient with rhabdomyolysis? Because bicarbonate, it will prevent the precipitation of a CPK, creatine phosphokinase, on myoglobin in the kidney tubules. Because what we're trying to do with rhabdomyolysis is to protect the kidneys from further destruction, and that can be prevented, and we can protect the kidney and prevent it from deterioration or getting worse. Is that we can add bicarbonate because that will prevent the precipitation of the CPK and myoglobin in the kidney tubules, and we can add mannitol to decrease the duration of contact of myoglobin with the kidney tubules, because the contact of myoglobin with kidney tubules is going to result in more renal dysfunction. Another scenario or case study here, we have it, which is the ESRD, end-stage renal disease. And you can tell here from slight elevation blood pressure. Patient has a history of HPI, of hypertension, diabetes, and renal insufficiency for several years. Medications, lisinopril, nifedipine, Januvia, and Micronase. So both, or 4 medications, 2 for blood pressure and for high blood pressure and 2 for diabetes. The indications for dialysis. So this is a good question about when would you prescribe or order dialysis for patient. It can be prescribed for all the following except one, except for fatigue. You can give it for hyperkalemia, for fluid overload, encephalopathy, metabolic acidosis, pericarditis. All the except A or fatigue can be indications for dialysis and it will be like for one session, most like most of the time for these conditions, other than end-stage renal disease, for these conditions will be most likely it's going to be for one session or one treatment session. That's it. And then, so the fatigue, we don't usually prescribe dialysis or recommend dialysis just for fatigue. Um, so the CBC, if you look at the CBC for this patient, um, hematocrit and MCV 85. Okay, so this concept is critical about or very important concept in renal dysfunction or ESRD, which is the chronic anemia due to the reduction in erythropoietin, EPO hormone. And we went over this in class, and this patient needs vascular access, which is AV graft for this patient. But we said that, AV shunt most likely is going to be like, or almost like all patients nowadays, they have AV shunts and not the grafts. So it will be created, and it's not until like you have to wait about 6 to 8 weeks for this AV graft to be or shunt to be mature to be ready for the dialysis. Um, And most patients, when the death of patients with end-stage renal disease, um, even when they are on dialysis, most likely the cause of death would be due to the coronary disease. So renal insufficiency greatly accelerates the process of atherosclerosis, because renal dysfunction or renal insufficiency, they augment or they accelerate the process of atherosclerosis, and that's why patients' death would be due to, or patients with ESRD, the death would be due to the coronary disease. Um, Patients, we said that they will also develop a hypocalcemia, hyperphosphatemia, low calcium, high phosphate, and we explained why patients with that would be presented with low calcium level, because the calcium level is low from the decreased level of vitamin D, and there are too many forms of vitamin D. We have a form which is like 1,25 dihydroxy vitamin. That's one form of vitamin D that's in which the kidneys are usually they activate this form of vitamin D. Um, and from we can also, if you want to just jot down this note on your note, or like under if you take notes, that due to the hypocalcemia response to low vitamin D, hypocalcemia in patients with ESRD, they tend to develop the hyperparathyroidism. Hyperparathyroidism, because the low calcium is going to constantly produce more parathyroid hormone, PTH hormone. So they will end up with hyperparathyroidism. And you can, again, write this down, this note down, or idea or concept, or because we're going to revisit this and the endocrine gland, endocrine diseases, endocrine system diseases. So, under the endocrine system, we will cover this concept, which is the patients with end-stage renal disease. They develop hyperparathyroidism. That's due to the low calcium, and response to that, the endocrine system or the hyperparathyroid glands will produce large amounts of parathyroid hormone in response to that. So it's just continuation from the previous case study is that almost like we said that the AV fistula needs 4 to 6 weeks to mature in terms of like epithelialization, and become like, mature enough to be usable for dialysis. So this patient will be, if we are going to do like emergent or like, urgent dialysis, then we can just insert a subclavian portacath, subclavian, catheter, and that would suffice for the instant and urgent dialysis. In the meanwhile, while we are waiting for the AV fistula or AV graft to mature. So if you have to do another, like dialysis, we can keep it that subclavian or that portacath. We can keep it there for these weeks until the fistula or graft is ready to be used. Review the medications, and one of the most important meds is the phosphate binders, Sevilla, Renagel or Renvilla, Renagel. That's one of the most important medications. Phosphate binders. Read about them, the mechanism of action, different types of them, and any nursing implications that has to do that we have to give them, administer these meds with meals to reach the most optimal effectiveness. Patient should be also on Procrit EPO hormone because they have a chronic anemia due to the low EPO hormone. Now, these are kind of miscellaneous questions. Who's here? Kim, can you take the first question, please?
A 60-year-old patient with long-standing diabetes has a creatinine of 3.6, which has been stable for several years. Which of the following antibiotics requires the most dosage modification in chronic renal failure?
Which medication from this list is the most detrimental to the kidneys and can lead to the kidney failure or acute kidney injury at the moment?
Antibiotics.
All of them antibiotics. But which one?
Gentamicin.
Yes, gentamicin. So many drugs require dosage modifications in chronic renal insufficiency. The drugs that are nephrotoxic may be contraindicated or used only with extreme care and renal insufficiency. We attempt to avoid these aminoglycosides. Aminoglycosides, one of them is gentamicin, amikacin, neomycin. All these are aminoglycosides. So remember this, aminoglycosides like gentamicin, vancomycin, cephalosporins, penicillins, sulfonamides. All these medications can lead to chronic renal failure. But the most nephrotoxic ones are the aminoglycosides and vancomycin. The most renal or nephrotoxic meds, aminoglycosides and vancomycin. That's nephrotoxic and should be try to avoid them, try to exclude them from the list of of antibiotics to be used for patients, especially if they have a renal insufficiency. Okay, next question. Trezia, who's next? Kim, I think I have Kim next to the list here.
A 57-year-old man is on maintenance hemodialysis for chronic renal failure. Which of the following metabolic derangements can be anticipated?
Which has to do with bones. And it's the stage that precedes the osteoporosis. It's the stage that precedes the osteoporosis called osteomalacia. So the chronic renal failure treated with hemodialysis results in predictable metabolic abnormalities. Now, the kidneys fail to excrete the phosphate. It will lead to the hyperphosphatemia, and that would fail to synthesize the vitamin D. So vitamin D deficiency will cause impaired intestinal calcium absorption. Now, the phosphate retention, so we have hyperphosphatemia, phosphate retention. We have defective intestinal absorption of vitamin D and skeletal resistance to the PTH hormone. Remember when I talked about the PTH hormone, parathyroid hormone, and that results in hyperparathyroid? That all of these mechanisms all combined together will lead to the hypocalcemia, and it's severe hypocalcemia. So the hypocalcemia will cause secondary hyperparathyroidism and increased PTH hormone production. So towards the end of this, all these pathophysiological changes will result in renal osteodystrophy. Renal osteodystrophy. So the osteomalacia, it's the stage that precedes the osteoporosis. It's not severe, but more, you can call this as a bone, the bones become fragile, but not like osteoporosis. So it's a stage that precedes the osteoporosis called osteomalacia. And in this case, if you read in the book about something called renal osteodystrophy, it's the mechanism goes around or would cover the phosphate retention, hyperphosphatemia, will go over the defective intestinal absorption of vitamin D, the skeletal resistance to the parathyroid hormone, PTH hormone, and all of that combined together will lead to the hypocalcemia. And eventually, the patient will develop renal osteodystrophy, osteomalacia, and other like orthopedic issues. But this is the most important one, which is osteomalacia, which is a stage that precedes the osteoporosis. So the weak bones or unhealthy bones due to that hyperphosphatemia and especially hypocalcemia. Because we know that the calcium and phosphate, they always have inverse relationship with each other. Okay, next, who's that? Dina, please. Dina?
Yeah. Which assessment data warrants immediate intervention by the nurse for the client diagnosed with chronic kidney disease who is on peritoneal dialysis?
And this is peritoneal dialysis. This is a catheter extended from or coming from the abdomen and peritoneum, and we have dialysate or the effluent. So dialysate comes in, flows into, stays in the, so we have inflow, dwell, leave it there in the abdomen, and then outflow or drain. So the drain came out, which is dialysate came, when we drained it, it came cloudy. So that's C, right? So that's the abnormal one. So the chronic kidney disease, who is on peritoneal dialysis, so dialysate become, removed from the abdomen is cloudy. The dialysate return should be colorless and straw colored, but should never be cloudy, which indicates infection. So the data warrant immediate intervention. Now, the patient with chronic or with CKD would have elevated creatinine. That's expected. We know that patients' creatinine will be elevated. So this doesn't warrant any like immediate intervention. B, it's peritonitis, inflammation, and peritonia. The peritoneum is serious complication that would result in heart. So that's sorry. That I mean C is the indication, or C, which indicates that patient has peritonitis or infection. B, patient's abdomen is soft. So that's, when it's board-like abdomen, that is a sign of, or rigid abdomen, that's a sign of peritonitis. So that's why C is the correct answer. When you install 1500 and you remove 2100, that's expected that the removal or the drained dialysate is always going to be higher than the inflowed or instilled amount or volume. So D is expected. I remember that. This is very important to know that the outflow or the drained amount or volume is always going to be higher than the instilled or infused volume. So that's expected. So next question.
Is it the second?
Where are we? We did stimulation.
Yeah, we're on this page, the second question.
Okay, we're here, right? Okay, so who's ready? Kareem?
Dialysis allows for the exchange of particles across a semi-permeable membrane by which of the following actions?
So this question, the concept here about the mechanisms that govern the movement of fluid or fluid movement across the membranes, which is mimics the natural intrinsic pathophysiology of our body, kidneys, and how the kidneys work in terms of removal of the waste products and buns and creatinine and other waste products. So the two mechanisms that would govern the fluid movement across the membrane and removal of the waste products by the kidneys, by the artificial kidney, by the dialysis, right, machine or dialysis mechanism of dialysis, is that the osmosis and diffusion. Because osmosis will allow for the removal of fluid from the blood by allowing it to pass through a semi-permeable membrane to an area of high concentrate, which is dialysate. Because dialysate, remember that dialysate is a hypertonic solution. So going to pull all these waste products from the blood by osmosis. The diffusion will allow for the passage of the particles, which is the electrolyte, urea, creatinine. So osmosis will remove the fluid, the excess fluid, the fluid excess, because the dialysate is a hypertonic solution. So it will pull the excess of the fluid from the blood. So fluid overload will be treated in patients with ESRD by osmosis, which is one of the functions of the dialysis machine would have at certain rates and certain velocities. And then the second one or second mechanism that would control the fluid. So the osmosis for fluid removal and diffusion for particles removal, the passage of the electrolytes, the urea, creatinine. Remember, patients with ESRD, they will end up they presented like right before the dialysis session, they would have a high potassium level, for example, hyperkalemia. So that potassium will be treated with or taken care of by the diffusion. So diffusion will pull the excess of the potassium from the blood, the excess of urea, creatinine, the bun, all of these particles will pass through from the blood into the machine to be discarded, excreted through this filter or the dialysis machine by diffusion. So these are the two main forces that would govern the movement of fluid and particles from the blood out in terms of excretion, through the artificial kidney, the dialysis machine. So it's kind of mimics the natural intrinsic pathophysiology of the osmosis and diffusion in our body. Any questions so far?
No.
Okay. All right. Who's next? Would like to take the next question? I have Nika, please. Nika, please.
A client is diagnosed with chronic renal failure and told she must start hemodialysis. Client teaching would include which of the following instructions?
Okay, so this is a chronic renal failure, and teaching. And it's one of the important concepts in when we teach the patients about hemodialysis is that we stress on their ability to follow the schedule. Because this is time and effort consuming. Like, they have to spend like hours and hours during the week, 3 to 4 hours per session, 3 times a week, transportation. It's a not an easy job here or task, to commit to. So they have to commit to this schedule. So the to prevent life-threatening complications like severe hyperkalemia, fluid overload, cardiac issues, and other life-threatening complications to be prevented, the patient should or must follow the dialysis schedule. So that's the answer. Next question, Andre, please.
A client is undergoing peritoneal dialysis. The dialysate dwell time is completed, and the dwell clamp is open to allow the dialysate to drain. The nurse notes that the drainage has stopped and only 500 mLs has drained. The amount of dialysate instilled was 1,500. Which of the following interventions would be done first?
Okay, so 500 and then stop. This is the peritoneal dialysis. We said
Mhm.
that the outflow or the drained dialysate always should be higher than or more than the instilled ones. So if you instilled 1500, you anticipate at least 17, 18, 2000, right? 1800 or 2000 or more even than 2000. So if 500 only drained and then stopped, we have to check for kinks or any obstruction. So the first intervention should be to check for kinks and obstructions because that could be preventing the drainage of the dialysate into the draining bag or onto the bag that we are draining that dialysate in. So after you check for the kinks and any um, modes of obstruction or cause of obstruction, you will have the client change position to promote drainage. So check just within like, a second or two, few seconds, you can just do this about checking for any kinks or obstruction. And then you ask the patient to change position, probably gonna promote the drainage. So we don't um, give the next scheduled exchange until the dialysate is drained because this can lead to abdominal distension. So don't attempt to or start the next session or the next dialysis cycle until you are you are sure that all that dialysate has been drained. Otherwise, you are adding more. So there is more dialysate in the abdomen, and you are adding another like 2,000 or 3,000 of the dialysate in addition to the amount that is being there and undrained from the abdomen. So don't attempt to do that. For this patient, we have to check for kinks and obstruction, and then we ask the patient. Next, we can ask the patient to change position. Now, if unable to get more output despite checking for kinks or changing the patient's position, we can and ask the patients, to change position. So it's unsuccessful. So both things are done. Then we can move on to the next step is to call the PCP to determine the proper intervention for this patient. Okay. Who's next? Jada, can you please take the next question? Client receiving hemodialysis treatment.
Yeah, hold on one
Thank
second. The top one, right?
Yeah. Mhm.
A client receiving hemodialysis treatment arrives at the hospital with a blood pressure of 200 over 100, a heart rate of 110, and a respiratory rate of 36. O2 sat on room air is 89%. He complains of shortness of breath and 2 plus pedal edema is noted. His last hemodialysis treatment was yesterday. Which of the following interventions should be done first?
So airway and oxygenation are always the first priority for, especially for this scenario, because the client is complaining of shortness of breath and the auto set is 89%. So obviously your answer, your bet, your best bet or the answer should be to administer the oxygen. So we will try to increase the level by administering the oxygen. The client is in a pulmonary edema from the fluid overload. Remember that patients with kidney or renal failure, they end up with pulmonary edema from the fluid overload, and they will need to be so they have to be to receive dialysis and to remove all that fluid. So we can remove all the fluid and prevent that, or at least maybe treat or maybe prevent the pulmonary edema. So the first intervention should be to provide immediate treatment of auto or oxygen um, to treat the hypoxia. So we will elevate, definitely we can also elevate the foot of the bed to reduce edema, but it's not going to be the first priority for this patient. Next question. Next, they have Janessa, please. You ready? Janessa, can you hear me? If Janessa is not ready, Dayanara, ready?
A client has a history of chronic renal failure and received hemodialysis treatments 3 times per week through an artificial fistula in the left arm. Which of the following interventions is included in this client's plan of care?
Yeah, and this is one of the basic and fundamental assessments, as well as interventional, because when you assess, you intervene sometimes, or can be treated as intervention. So in this case, and this is one of the most important, you anticipate questions in my exams, academic exams, but the how would you assess for the functionality or the fistula is working and it's functional, it's ready to be used. Otherwise, patient, we have to fix it or create a new one. So it's critical because that's important that we have to do this like at least once per shift. If that's 12-hour shift, I would say twice per 12-hour shift. So we have to do this, make sure that this fistula hasn't become occluded, it's not blocked, there's no blood clot, and it's usable. So we assess for AV fistula for Brui and thrill. Very important. We said Brui auscultate, thrill, palpation. So if not present, so we have to say it's positive for both Brui and thrill, B/T, B/T positive for AV fistula. So if not present, occlusion, blood clot, or so it indicates a non-functioning fistula. And that's critical because that patient, if the patient is due for dialysis that day or next day, we can't use it. So we should create or have other alternatives, options like a portacath, subclavian or intrajugular or subclavian catheter to be inserted for that day, until we figure out or either clear or treat or remove the occlusion or blockage or blood clot or from the old AV fistula, or sometimes we have to create a new one. So also read about no blood pressures or venipunctures should be taken in the arm with the AV fistula or AV graft, same thing. Okay, next question. Let's see here. Shanti, ready for the next question?
Which of the following factors causes the nausea associated with renal failure?
So patients develop nausea, and this is more known manifestation of in patients with end-stage renal disease. They have nausea and sometimes vomiting. So the GI symptoms. What is the source of the GI symptoms? Patients with renal failure, they can develop stress ulcers. They may develop stress ulcers, but the nausea is usually related to the poisons of metabolic wastes that accumulate when the kidneys are unable to eliminate them. So kidneys are unable to eliminate the waste products, and these, especially the urea, the blood urine nitrogen. So the accumulation of waste products are as the source of the nausea in patients with end-stage renal disease. So the next question. Rose, you ready?
The client with chronic renal failure is at risk for developing dementia related to excessive absorption of aluminum. The nurse teaches that this is the reason that the client is being prescribed which of the following phosphate binding agents.
Yeah, these are some of the questions, or I mean, concepts that would be taught to patients, especially because these are OTC drugs, over-the-counter medications, and we try to teach them to avoid these meds because this, especially the meds or OTC drugs that are high in phosphorus or phosphate. So, like Tums, they are made from calcium carbonate and bind, and they also, bind the calcium carbonate with phosphorus. So Tums are prescribed to avoid the occurrence of dementia related to high intake of aluminum, but it's um, so the phosphate binding agents are needed by the client in renal failure because the kidneys cannot eliminate phosphorus. So all the drugs except the Tums are made of aluminum, and aluminum has so these drugs are made from aluminum hydroxide. So the Tums are made from calcium carbonate and also bind phosphorus. It's not in a sense that it's composed of phosphorus, but it will bind to the phosphorus. In other words, that it will take care of the phosphate. So they are prescribed. So they have like two good functions. First, the Tums are going to be prescribed to avoid the occurrence of dementia. So it can slightly treat dementia related to high intake of aluminum. Because there was, they have evidence-based practice showing that there is a high correlation between aluminum intake or excess aluminum intake and dementia and Alzheimer's disease. So the Tums are prescribed to avoid the occurrence of dementia related to the high intake of aluminum. And also Tums are made from calcium carbonate. It's going to bind phosphorus and GI tract. And so all the medications except for Tums are not good for patients with kidney failure because of the aluminum. Okay, Chelsea.
A client newly diagnosed with chronic renal failure recently has begun hemodialysis.
Knowing that the client is at risk for disequilibrium syndrome, the nurse assesses the client during dialysis for
Is that D?
Okay, so it's a CKD or interstitial disease, began hemodialysis, disequilibrium syndrome. What are the signs and symptoms more consistent with disequilibrium syndrome?
Restlessness is usually one of the key markers for this equilibrium system, no?
Restlessness,
So,
no, it's change of level of consciousness. So altered mental status, headache, it's more of mental confusion, more than restlessness. So this equilibrium syndrome, the rapid removal of the urea, the brain cells will be reacting to that fast removal of the urea by the hemodialysis, by this equilibrium syndrome, which will be characterized by headache, mental confusion, decreased level of consciousness, nausea, vomiting, twitching of the muscles, and possible seizure activity. So whenever you see seizure activity or muscle twitching, headache, mental confusion, change of level, which is decreased or deteriorating level of consciousness, these all classic signs of this equilibrium syndrome. And again, this syndrome is caused by rapid removal of waste products, most known as the blood urea nitrogen, from the body during hemodialysis. So at the same time, the blood-brain barrier would interfere with the efficient removal of wastes from brain tissue. And as a result, water goes into cerebral cells. So the water will gush into the brain cells, the cerebral cells, and result in because of this osmotic gradient, so it will result in a brain cell swelling and edema, like cerebral edema, and all these symptoms are will result in response of this mechanism and cerebral edema, swelling of the brain cells, and the patient will be presented with all these symptoms, the headache, the GI symptoms, and the decreased level of consciousness, muscle twitching, mental confusion, and possible, or even seizure activity. All these are symptoms in response to the cerebral edema. So the optimal treatment for a patient who is presented or assessed to, we believe that the patient is presented with this syndrome, is to make sure that we have anticonvulsant, anti-epileptic drug ready for the patient. Next question. Okay, Joy, please.
A client with chronic renal failure has completed a hemodialysis treatment. The nurse would use which of the following standard indicators to evaluate the client's status after dialysis?
So it's vital signs and weight, right? So following dialysis, the client's vital signs are monitored to determine whether the client is hemodynamically stable or not. So weight is measured and compared with the previous, like we have to weigh the patient before and after, pre and post dialysis, to determine the amount of the fluid being removed or extracted fluid removed from the body. And we see the effectiveness of the dialysis session by knowing this a good amount of fluid being removed. Next question. Zena, ready for our next question?
We're on the second question, correct?
We are on client is admitted, the first one.
A client is admitted to the hospital and has a diagnosis of early stage chronic renal failure. Which of the following would the nurse expect to note on the assessment of the client? Is it polyuria?
Early stage polyuria. Yeah. Polyuria, then it progresses to late stage to anuria, and the client will lose the normal function of the kidney by having this oliguria or anuria later on. But early sign will be polyuria.
But Professor, I have a question.
Yes.
Polyuria will be a lot of urine, not a little. Would start with oliguria, then progress to anuria, no?
So the polyuria occurs early in chronic renal failure due to it's like compensation. The kidneys try to compensate for it's an early sign. It sometimes won't last like couple of hours, like a few hours, and then patient progress into the acute episode or illness, or the kidneys fails to continue with this compensatory mechanism. It's like more compensation to the acuteness of the disease, and the patient later on will progress into the complete failure, which is either anuria or oliguria.
Okay.
Did I answer your question?
No, just more familiar with polyuria being more of a diabetic thing as opposed to a, ESRD thing.
Oh, you mean why polyuria? It's I mean diabetes. Oh, and diabetes we understand why, because that's the osmosis.
Right.
Because osmosis function. But here it's more of the kidney function. The kidney. It's kind of evaluates the kidney. So when we evaluate the kidney, we look at the urine output, about the electrolytes and so forth. So the urine output by itself, it's a sign of renal function, healthy or unhealthy. So the early sign of unhealthy kidney would be polyuria. Then later on, like again, it won't take longer until the kidneys fail. So remember, we're like heart failure, CHF, same thing, right? So heart will try to attempt to compensate, and then it'll become decompensated. Same thing here with the kidneys. And all these organs, they attempt to compensate, but won't last longer. So for CHF, for example, ejection fraction would be high for the first stage of the disease process, and then eventually patient heart would fail completely to ejection fraction becomes very very low. Something I mean similar to the cardiac would be kidneys. Kidneys here would have polyuria but won't last longer than then eventually would presented with the complete failure, which is the anuria or oliguria.
Okay.
But the diabetes is the mechanism is completely different than what we have here. Yeah.
Thanks.
Okay, good. Okay, next question. Nurses performing assessment. Volunteers, or who's next? I have.
The nurse is performing an assessment on a client who has returned from the dialysis unit following hemodialysis. The client is complaining of a headache and nausea and is extremely restless. Which of the following is the most appropriate nursing action?
This is very, I would say, obvious scenario of a patient with headache, nausea, and vomiting, or nausea.
Is this equilibrium syndrome?
Exactly. So out of the 4 options here,
notify the physician.
Yes. Yeah, because there is rapid decrease in bun levels during dialysis, resulted in disequilibrium syndrome. We have to call, notify the PCP. Yeah. Next question. What do I have here?
The
Denasia,
nurse
please.
is reviewing a list of components contained in the peritoneal dialysis solution with the client. The client asks the nurse about the purpose of the glucose contained in the solution. The nurse bases the response knowing that the glucose.
D.
So increasing the glucose concentration, it will make the solution more hypertonic. So the more hypertonic the solution is, that would result in higher osmotic pressure for ultrafiltration, and then great or higher amount of fluid removed from the client during the exchange. So ultrafiltration is the third mechanism that would govern the movement of fluids from the patient's blood into the dialysate, or through the machine, through the filter, the artificial kidney or filter, the dialysis machine. So we have osmosis, removal of fluids, diffusion, removal of waste products, and then ultrafiltration, more fluids will be removed. So if we need to remove higher amount or high level or higher volume of fluid to be removed, then we will activate the ultrafiltration mechanism or force. That's the third mechanism that would govern the movement of fluids and waste products from or using the dialysis machine. And again, all of these mechanisms, they mimic the patient's or in human kind of intrinsic natural mechanisms that will govern fluid movement across the membranes or compartments. So D, correct answer. All right, what I have next is Leo. Can you please take the next question? Leo, can you hear me?
Yes, a client newly diagnosed with renal failure is receiving peritoneal dialysis. During the infusion of the dialysate, the client complains of abdominal pain. Which action by the nurse is most appropriate?
Okay, so during the infusion of the dialysate, the client complains of abdominal pain. Now, actions. So pain during the inflow of the dialysate. So we said inflow, dwell, and then drain. So this is pain during the inflow of dialysate is common during the first few exchanges because of this is new procedures to the patient's peritoneum, and there will be some irritation to the peritoneum that would be present during the first few exchanges or sessions or dialysis sessions. So peritoneal dialysis, we anticipate the peritoneum to be irritated. So this is peritoneal irritation that has resulted from the new product, new fluid, new dialysate, something new to the peritoneum. So the irritation to the peritoneum that is expected during the first few exchanges with the dialysate, with the peritoneum. So we would explain that the pain would subside after the first few exchanges. So pain would disappear. Sometimes it will last like up to 2 weeks of treatment. We can treat patients' pain if that's something that should be treated with pain management, any drugs, medications, or OTC drugs. But we will explain to them that this is expected for the first 2 weeks of treatment, given that explanation of that mechanism.
Professor, I have a question.
Yes.
Pain could also be because the dialysate is cold, right?
Yes, exactly. But exactly. So cold dialysate can also lead to abdominal pain, but we have to exclude that. So we have to exclude if one of the options said like, pain, then I mean cold dialysate, that would be the answer, yes. So that's why the dialysis should be like, close to the patient's, internal body temperature. We have to warm it up, so have to be warm, not cold, that to prevent the abdominal pain.
Professor,
Yes.
quick question. I'm actually certified in PD dialysis. They always
Yes.
tell me that when there's pain in the first few weeks, you're supposed to slow the infusion because the abdomen has to get used to it. It does subside after a few weeks, but initially you're supposed to actually slow the infusion, being that it's
Slow
not
the
really
infusion.
it's more of
Yeah.
an amount thing than it is a rate thing as opposed to like an IV.
Yeah. So for this one, okay. So let's look up the question. So the first few weeks, so this is new to the patient, right? If we expect it to first few exchanges that there will be some abdominal pain, then I don't think slowing the infusion will be the best answer, at least according to what I have here, according to this scenario. So this is what you learned. Is this like typical for all cases? Is that you have to slow the infusion regardless?
I mean, this is what they taught us. They said, like, once the patient begins this initially, the abdomen has to get used to that, influx of fluid, which doesn't ever happen. It's an unnatural phenomenon. So,
Mm-hmm.
so the rate being that
Yeah, that's
they have to get
requires that
whatever
we have. Yeah,
2,000 mLs.
I can look into the best best answer for this scenario. If that's to slow the infusion rate or
Yeah,
to
because it's not really a doctor's order
uh
of the
yeah,
rate.
yeah.
You know,
So
actually,
new
if you use the automatic machines, they'll slow the rate if they feel obstruction.
right.
And sometimes the sort of like the initial stages of the healing process of the PD
Mm-hmm.
catheter
Mm-hmm.
on the inside actually mimics the effect of an occlusion, and it
Yeah,
will automatically slow the rate.
yeah. Good point, Samja. I think it's a good point to look into what would be the best answer. Is it to slow the infusion? So new I'm going to look into the like evidence-based practice and up to date in terms of the new peritoneal dialysis and during the infusion, like during the inflow,
Yeah.
would you on patient complain of abdominal pain? I'm going to write in this notes, I'm going to look into the best answer for this. So do we have to slow the infusion or to explain it to the patient that this is like expected and normal, right?
For reference, my training happened within the past year, and
Hmm.
I applied to Vita in person at their PD centers.
Thank you. I mean, thanks for sharing with us. And I definitely have go, we'll go into to see the evidence best practice and and research like studies or up to date.
Yeah, let me
They
know.
will also provide us with the up to date stuff. We'll see. Thank you. Thanks. Um, good. So next question.
The client with chronic renal failure who is scheduled for hemodialysis this morning is due to receive a daily dose of enalapril. The nurse should plan to administer this medication on the return from dialysis.
Right. I think we went over this concept, a few
Mm-hmm.
times in class. And next question. Okay, who's Janasia? Can you hear me?
Yes, I can hear you.
Thank you. Can you take this question, please? The client with an AV shunt in place of for
Okay.
hemodialysis.
The client with an arterial venous shunt in place for hemodialysis is at risk for bleeding. The nurse would do which of the following as a priority action to prevent this complication from occurring? Um,
So
should be
the
an
AV
risk.
shunt is less common form of access site, and but will carry the risk of bleeding when it's used because we have two ends of external cannula are tunneled subcutaneously into an artery and vein, and
Mm-hmm.
that's when they create the shunt. They will like suture the vein with the artery, and the ends of the cannula are joined. So if accidental connection occurs, then the client could lose blood rapidly. So for this reason, small clamps are attached to the dressing that covers the insertion site to use if needed. So
D.
the answer is going to be D. Yes.
Okay.
Yeah. So this is just to show there are key considerations, like key points about the AV fistula, and the link or I think it's a YouTube video about the fistula, another key points, and then we have questions. What would be the primary disadvantage of using peritoneal dialysis for long-term management of chronic renal failure? And this is peritoneal dialysis.
Is it B or C? One of those two?
It's B
No,
or
actually, it's very
D.
effective. When it comes to B, it cannot correct severe imbalances. No, it's very effective, similar to the hemodialysis. Patients live with, with ESRD on peritoneal if they are eligible, eligible, if they are good candidate and they are compliant and they are like good cases for that. That would be perfect treatment for them. Similar to the effectiveness would be equivalent to the hemodialysis to some extent, I would say, but it's very effective for these patients. So, say B, B shouldn't be the answer. So the danger of hemorrhage, right? No, there's, very minimal risk, but the D, hepatitis, like hep, it's just would be expected from hemodialysis. So it's more of time consuming. Yeah, it is a time in terms of that patient will, even though that, most of the time that will be done during nighttime, like during the sleep hours, but it's like it's very long hours compared to the to the hemodialysis. Long hours. That's why. Next question. The client with chronic renal failure tells the nurse he takes magnesium hydroxide, which is MOM, milk of magnesia, for constipation. If you have a patient with, let's say, chronic constipation, and you want to put them on a OTC drug, try to avoid milk of magnesia. And any drug that is with the magnesium content, because that can increase the magnesium level and result in magnesium toxicity. So the protocols for constipation prevention should exclude patients with ESRD from the use of magnesium of the milk of magnesia, and we can administer magnesium-free stool softeners or laxatives. So this is one of the major concepts also here is you can use lactulose, for example, as a form of laxative that can be replaced this product. So try to avoid the milk of magnesia or any product that has a magnesium component in it. Client with chronic renal failure asked to be evaluated for home continuous, which is peritoneal dialysis. It's a form of a peritoneal dialysis. The major advantage of this approach is to allow the client to be more independent. They will be at home setting, taking care of their own disease at home. Self-management will be completely 100%. I would say almost 100%. And they will take care of their own. They don't have to travel to the dialysis centers. They don't have to go to these, clinics for dialysis session. They will have their own machine, home setting, and they will take care of it. And so that independence, that's a valuable outcome for some people or for most people. So it's costly, but it must be done daily, and it's more of maintaining independence for these patients. So that's all about the hemodialysis and peritoneal dialysis, and the Neuro. I can go over if you want to stay another like 30, maybe 40 minutes. I can go over the questions to cover the rest of the newer questions. If that's okay with the group. Otherwise, I mean, um, also we're still recording the session, so for those who are unable to attend or must leave for other classes or other assignments or responsibilities, then this session is being recorded.
Yes, Professor, I'd like to review the newer questions.
Yeah, I'll be staying.
Okay. So let's take a few minutes. Let's just look at the recording. Okay, so number five, you said, right? Four, sorry. Yes. Four. Andrew, you want to take that question?
Yeah. I just want to make sure it's the same. It's a client with a contusion. Is that the one?
Yeah.
Okay.
With contusion. Yeah.
A client with a contusion has been admitted for observation following a motor vehicle accident when he was driving his wife to the hospital to deliver their child. The next morning, instead of asking about his wife and baby, he asked to see the football game on television that he thinks it's starting in 5 minutes. He is agitated that the nurse will not turn on the television. What should the nurse do next? Select all. I know we said it
Two
was
and three.
two or
Yeah.
three,
We went
right?
with two and three. So they would determine if the client's pupils are equal, react to light, and you ask the client if they have like signs or symptoms of headache,
Mm-hmm.
confusion, agitation, restlessness, because all of these are subtle signs or manifestations of increased ICP.
And the Cushing's
So these
triad.
are So two
Okay.
and three most important. Yeah.
Okay.
Five. Let's just go to five. Okay, five. Who's here? Appreciate. You want to take the number five, please?
Wait, what number are we doing?
It's projected on the screen.
Five.
To share with you.
Participants of
Yeah, number five.
motion exercises have prescribed for a recent CVA client with left hemiplegia. Which of the following would be the most important for the nurse to include in the exercise treatment plan?
One.
One. Is it number one?
Yeah, exercise on the first day of, yes, absolutely. Yep. And then number six. Yeah, I think we went over this, and I'm not sure section first or second section, but we said it's the nerve number 10, the cranial nerve number 10, that's in which that we will assess for swallowing, right? The gag reflex, which is a tongue blade that should be used for that assessment, right? All right, and then number seven.
Which of the following is a priority when suctioning a client with increased intracranial pressure? One.
Right. Yeah, limited to the 30 minutes. Yeah. Okay. Um, yeah, number 8.
In planning the post-op care after cranial surgery, the nurse should place the client in which of the following positions? Oh, hold on, I can't see the options. 3, elevate the head of the bed.
Yes, and rationale for this one?
They can't be flat side or Trendelenburg because all of those will increase the cranial pressure post-op.
Yes. So that's the best position to lower the increased ICP. Yeah. All right, number. And okay, the first one here with the TBI brain. I believe you went over this one, right? In class, we said the answer is elevate the head of bed, contact GCP, and monitor for neurological status, or I mean using the Glasgow scale. So it'll be like 2, 3, and 4. And we should maintain ICP by elevating the head of the bed, call the PCP. If the ICP is higher than 20 millimeter Hg mercury, higher than 20 indicates high ICP, and so that's when you would contact the PCP, and then any coughing, range of motion exercises, or sneeze, and all these um, uh, things are going to increase ICP and should be avoided to some extent, especially post-op stage, like to give patient antitussives, patient give patient medications to prevent any source of increasing the ICP. So that'll be number 1. Okay, the second question. The nurse is monitoring client with increased ICP. Indicators that most critical for the nurse to monitor. So things that are going to be listed as manifestations or criteria, or criteria that will be consistent with the increased ICP. So manifestations are going to be monitored. The nurse should monitor the systolic and diastolic blood pressure to obtain the mean arterial pressure. Because remember that patients with increased ICP, they would have an increased systolic and slightly high diastolic. In other words, that there is a wide pulse pressure that may adversely affect the MAP, the arterial pressure. So that would represent the pressure needed for each cardiac cycle to perfuse the brain. So that's eventually is going to wide pulse pressure, decreased perfusion to the brain, and that would be an indication for increased ICP. So we also should monitor the CPP, cerebral perfusion pressure, and the equation says that cerebral perfusion pressure. So let's see if I can write it here on the slide. I would write it in the chat. CPP equal MAP minus ICP. Okay, so you'll find the equation in the chat. It says that the cerebral perfusion pressure equal MAP, the MAP, minus ICP. So we should monitor the patient's CPP which is obtained from the ICP and MAP. And we should also monitor patients' urine output because that's also another sign of increased ICP. So, but it's urine output. They are needed to maintain the ICP, but not cerebral perfusion pressure. So the ones that are going to be consistent with the with the ICP as most critical for the nurse to monitor will be 1 and 4, systolic and CPP. Systolic and CPP. I mean, urine output is not that critical because it doesn't going to be any significant outcome from increased ICP. Slightly affected, yes, but it's not significant. The most significant will be systolic and blood pressure and CPP. 3, when you measure the MAP equation equals, again, I'm going to also write that in the chat, which is another equation that when you can get the MAP, mean arterial pressure equals, in parentheses, systolic blood pressure plus 2 diastolic blood pressure. And then all of these combined, all these numbers, when you get all the numbers here, divide that over 3. And that will be the patient's mean arterial pressure. So that's another equation you'll find in the chat. You'll find in the chat, which is number 4. Number 3, which is 120 plus 260s, another 120, divide by 3, that would be lead to 80, result in 80. The answer is 80 millimeters Hg. Number 4, so the client with contusion, and we answered this question and we said it's 2 and 3. So the answer is 2 and 3. So we will determine if the client's pupil are equal and reacted to light or reacted to light. So that's purula, number 1. Second, and we should ask about headache because the contusion, the patients, or we should determine if the client's pupils are, so we assess for the pupils and ask the patients, they have headache. So the confusion, agitation, restlessness, or these are subtle clinical manifestations of increased ICP. And I went over this earlier. So the answer is 2 and 3. Number 5. Who is ready to take the question?
An unconscious client with multiple injuries arrives in the emergency department. Which nursing intervention receives the highest priority? Neck fracture? Checking for neck? No.
So unconscious client with multiple injuries arrived to the ED, right? So which intervention? So again, this is highest priority. It means sometimes you have all the 4 options, like, for given options, or so always airway. Yes. So the highest priority for client with multiple injuries is to establish an open airway for effective ventilation and oxygenation. So unless the client has an open or patent airway, then all other care measures will be like obsolete, like they doesn't have any importance and significance. So number 6, client is at risk for increased ICP, which the following should be again, priority for the nurse to monitor. So the answer is unequal pupil size. Remember the previous question, I think one of them. number 2 or 3, the answer was the pupil assessed for pupils, right? PERLA. So increased ICP caused unequal pupils as a result of pressure on the third cranial nerve. So you will find not both of them will react to light. Sometimes you'll find one of them is unequal pupil size. So, I mean, one is reacting, one not reacting. So unequal pupil size in terms of reaction and size as well, both. So unequal pupil size is one of the signs of increased ICP because that's a sign of or indication that there is an increased pressure on the third cranial nerve. So the number 7.
What should the nurse do first when a client with a head injury begins to have a clear drainage from his nose?
Okay, so remember the halo sign? So the clear drainage must be analyzed to figure out and to determine whether the nasal drainage is a CSF or not. So the halo test should be done. So the nurse should not give the client, sorry. So we said we test the halo sign by allowing the drainage to get into this piece of tissue or like gauze, and you will see like a liquid, kind of clear liquid around surrounding the blood clot. That's a sign of like a positive halo sign for the CSF drainage. Okay, number 8. Which of the following respiratory pattern indicates increasing intracranial pressure in the brain stem? And the slow, irregular respirations, because there is a neural control of respirations will take place in the brain stem. Brain stem is responsible. The breathing center which controls the breathing. It's in the brain stem. So any deterioration and pressure that would reduce or produce irregular breathing pattern, rapid, shallow respirations, asymmetric chest movements, and nasal flaring are all characteristics of respiratory distress or hypoxia. But the slow, irregular respirations are a sign of increased ICP. 9. Which of the following nursing intervention is appropriate for a client with an increased ICP of 20? We said the normal is up to like 15, like from 0 up to 15, or less than 15. So hyperventilation causes vasoconstriction. Hyperventilation. Remember that hypoventilation results in more CO2 retention, and CO2 is a vasodilator. So hypoventilation will result in a vasodilatation. Hyperventilation will result in vasoconstriction. And we always remember what the 3 components of ICP, intracranial pressure, would result from the brain cells, brain, blood in the brain, and the CSF fluid. So blood vessels dilated in the brain, dilatation of blood vessels in the brain, more blood, high ICP. Vasoconstriction in the brain, less blood, decreased ICP. So obviously the CO2 retention is not good for increased ICP. We need hyperventilation, not hypoventilation. So the hypoventilation will result in increased ICP. Hyperventilation would result in vasoconstriction and decreased ICP. Decreased ICP. And same thing also, it will decrease also CSF fluid and blood volume. And these two components will result in decreasing ICP over 20. So the answer for this one is going to be, what would be the answer for number 9? Answer for number 9, based on the explanation I provided.
3.
3, yes. All right, number 10, the nurse is assessing client with increasing ICP. When would you notify the PCP? On which of the following conditions would you notify the PCP on which of the following conditions? Some of the are distractors, even though they are like correct for that specific like condition, increased ICP. We know that increased ICP would result in wide pulse pressure. But which one is more of worse than the like out of the when you assess the 4 or evaluate the 4 options, some of them are distractors, even though they are considered to be correct and accurate to that specific condition. But which one is the most
Decreased level of consciousness?
right? Yeah,
Yeah.
the most one is going to be detrimental to the patient. It's not the wide blood pressure or decreased, pulse rate or dilated fixed pupils. It's more of decrease in level of consciousness. So the decrease in level of consciousness is an early indicator of deterioration of the patient's neurologic status. So changes in level of consciousness, such as restlessness, irritability, maybe these are the signs should be reported. So widening of pulse pressure, decrease in pulse rate, and dilated fixed pupils, they might result in a later stage, and they are not early signs. So late stage of increased ICP, later on, patient may develop wide pulse pressure, decreased pulse rate, or dilated fixed pupils. But the early signs, so that's why we have to take care of the early signs of increased ICP, decreased level or changes in level of consciousness, especially decreased level of consciousness. Now, 11, patient sustained increased ICP of 20. The most appropriate, we said, is head of bed elevation, right? So number 1. Number 12, and we went, because, we went over the same concept of head of elevated that will increase drainage, ICP, drainage from the brain by gravity, and that would eventually decrease ICP. 12, when you administer the mannitol, osmotrol, to a client with increased ICP, so we have parameters that would require close monitoring. What exactly you're looking for to say that, the drug been effective, the drug did good job, or so after you administer the mannitol, you would closely monitor the patient's what of the following, because the mannitol promote something. So the mannitol it has some type of mechanism to treat patients with increased ICP. What exactly that mechanism, and how you are going to determine the effectiveness of the drug based on the parameters patient is going to exhibit? Anyone
It's
can answer.
it's a osmotic
Diuretic,
diuretic.
exactly.
So
So
you
you're
have to
looking
take
for
the intake and output.
Intake and output.
intake and output. Exactly. So we are going to monitor the patient intake and output because mannitol promote diuresis. It's a osmotic diuretic medication. It's very effective for cerebral edema, and one of the best medications as we speak. It's been an old drug to treat cerebral edema, and is given primarily to pull the fluid and water from the extracellular fluid of the edematous brain cells, and it can cause the mannitol. it can cause hypokalemia and can lead to muscle contractions, not muscle relaxation. And the wide pulse pressure and the pupil dilatation, it's not a sign of this drug, but it's more of it's a sign, expected sign from the disease process itself, not the drug. So intake and output, it's critical. Now, 13, patient admitted with the spinal cord transection at C7. Transection means transection.
The spinal cord is no longer connected.
Yeah, complete cut. Complete cut. It's not an injury. It's not edema or trauma, or it's a trauma resulted in a complete transection, means separation of the spinal cord. So the assessment takes priority upon the patient's arrival. 3,
4, 5.
4, and 5. So you should assess the client for spinal shock, which is the immediate response to spinal cord transection. Hypotension occurs and the body lose core temperature to environmental temperature. So you will treat the client immediately to manage hypotension and hypothermia. You also will ensure that there is an adequate airway and respirations. Number 14. So the nurse assessing client for movement after halo traction placement. These are two two examples of the halo tractions with different brand names or different vendor names. So they are placed for a C8 traction, and so you would document which of the following for this patient.
4. 4.
4. So the correct motor function test for the C8 is a hand grasp check. So you have to assess for hand grasp and patient's ability to do that. The motor function check for C4 to C5 is when you do the shoulder shrinking or shrugging, kind of shoulder shrug would be done for a C4 to C5, C4, C5 injury. Against so you will press against the shoulders and you see the shoulder shrugging against that pressure. You have done, I'm sure they have done this in 235 in the assessment course. So the examiner hand goes on both shoulders, trying to press against the shoulders, and then the patient will attempt to do the shoulder shrugging. That kind of action evaluates the patient's, the C4, C4, C5 motor function to the C4, C5 injury. So, or healthy patient with no injury, you can check for that. So the motor function check for C5 to C6, how would you do that? How would you do that? So number one is trying to review with you the assessment techniques. Like number one, to assess for the motor function check for C4 to C5. What about number two? The arm pulls up from resting position against resistance. Number two. That's the check for C4, C5 to C6. Number two. And number three, the client's arm straightens out from flex position against resistance. And this is the assessment technique to assess or to check for C7, the motor function check for C7, you do number 3. So number 1, to check for the motor function, check for C4 to C5. Number 2, to assess for the motor function, check for C5 to C6. And then number 3, to check for the motor function, check for C7. And then obviously for C8, the answer was number 4. So that's number 14 and number 15. 4 days after surgery for internal fixation of C3 to C4 fracture. So as you move the client from the bed to the chair, and you check for, the wheelchair for correct features for this client, which of the following features of the wheelchair are appropriate for the needs of this patient? Back at the level of the patient's scapula, back and head that are high, yes. Seat that is lower than normal, yes. Seat with firm cushions, no. Chair controlled by client's breath, yes. So 2, 3, and 5. So the client with C3 to C4 fracture, they have a neck control, but may tire easily. So they get tired easily. Using, because they use the sore muscles around the incision area to hold up patient's head, trying to hold their head. So they will have like a lot of pressure on the incision area. So therefore, the head and neck of the patient's wheelchair should be high. The seat of the wheelchair should be lower than normal to facilitate transfer from bed to chair. And when the client attempt or can use hands and his hands and arms to move the wheelchair, the placement of the back of the client's scapula is necessary. So this client cannot use his arms and will need an electric chair with breath, chin, or voice control to manipulate movement of the chair. The firm, why the firm, firm or hard cushion is not good, because it would add pressure to the bony prominences, and that's going to eventually lead to skin pressure ulcers. So instead, the cushion should be padded to reduce the risk of pressure ulcers. So that's why answer is 2, 3, and 5. Okay, 16. Male client with the head injury regains consciousness after several days, which is the following nursing statements is most appropriate as the client awakens. Most appropriate is number 4. So it's important to explain, or to orient the patient to environment, explain where the client is, or to orient the patient to time, person, and place. So offering to get his family and asking him questions to determine whether he is oriented are important. But the first component, or the first thing and comment, should let the client know where they are. So there was in terms of to reinforce, to maintain orientation to the patient. Okay, and then 17. Patient who's regaining consciousness after craniotomy becomes restless. So craniotomy is it's an open incision into the cranium, into the brain, and because so attempts to pull out the IV line, which is the following, or nursing interventions protects the client without increasing ICP. Restrain the patient, or
Mittens?
yes, mittens will be the least, right, restrictive. So it is it's appropriate and more effective, and it's best for the client to wear mittens, which would help prevent the client from pulling on the IV without causing additional agitation. It's way better than the least restrictive than the jacket restraint and other applications, because jacket or wrist restraint or tucking the client's arms and hands under the draw sheet, all these measures will be restricting the movement and add to patient's frustration and feeling of being confined, and all of which would increase also patient's ICP. 18, which activity should the nurse encourage the client to avoid when there is risk for increased ICP?
Is it coughing?
Yes, because coughing is contraindicated for a client with the risk of increased ICP. So the answer is yes, 3, coughing. Okay, 19. Which of the following is most effective in assessing the client suspected of developing diabetes insipidus? And I believe that we are going to cover this under the endocrine system disorders. But for now, the answer is 2, because diabetes insipidus has to do with the ADH hormone. Patients with diabetes insipidus with DI, because they have deficiency in ADH hormone, antidiuretic hormone production from the posterior pituitary gland. So this condition requires a result in like patients with diabetes mellitus, like they have polyuria, polydipsia. These two manifestations, they're also consistent with the diabetes insipidus as well. So patient has polyuria and polydipsia from deficiency of ADH hormone. So they'll be extremely thirsty. They will have a large amount of diluted urine, polyuria. Urine will be large amounts, a huge amount of urine diluted. So number 2, measuring urine output hourly, that's a must in patients with diabetes insipidus. And I mean, this question pertains to neuro because it's a patients with head trauma, with traumatic brain injury, sometimes end up with diabetes insipidus. Question number 20, client who had a serious head injury with increased ICP to be discharged to the rehab facility. So which of the following rehab outcomes would be appropriate? And the recovery from serious head injury, it's a long-term process that may continue for sometimes months and even years after the injury. So depending on the extent of the level of the injury and extent and level of injury, the clients who are transferred to rehab facilities most likely will continue to exhibit cognitive and mobility impairment, as well as behavior and personality changes. So they will have cognitive and mobility deficits or impairments, as well as behavior and personality changes or alterations. So the client should be expected to practice, they should be participating. So we would expect the patient to be part of and participate in the rehab tasks and efforts to the extent that patient is capable of doing. So to the utmost capacity of the patient. So number 3 is the correct answer, to actively participate in the rehab process as appropriate. That's the most important concept or item or expectation, and ultimately that would result in a more effective rehab outcomes towards the end. So the family members and significant others, they will need long-term support to help them kind of cope with the changes that have occurred to the client. But the answer is 3. 21. Which of the following describes decerebrate posturing? Remember that decerebrate and decorticate posturing, they are, sorry, these are two different positions. The top one is decorticate, which is the inward contractures. Decorticate. Decerebrate posturing is the external contractures, inward and outwards, like internal and external. So internal decorticate, external decerebrate. So decerebrate is just more of describing.
It's just their hand positions.
I'm sorry?
It's just their hand positions.
It's more, no, it's both actually. It's the both legs are extended, so rigid extended, same for both, right? Some for both. The only difference is between the decerebrate and the decorticate top, and the decerebrate is the inward for the contraction of the arms and hands, right? And the outward for the decerebrate.
Okay.
So, I mean, the question is basically is asking about the best describes the decerebrate posture. So decorticate inward, decerebrate outward. So decerebrate is going to be
outward.
Exactly. So the you exclude the internal rotation, first one, and then the back hunched over, rigid flexion. No supination and pronation of the arms.
Yeah, right.
That's not part of it. But number 4 is the correct one, which is back arched, rigid extension of all 4 extremities. Because decorticate, it's external, right? Or in outwards. Back arch that for both. Legs for both. The only difference is the extension, and it's basically extension of both lower extremities for both conditions, but the upper extremities, here we have all 4 extremities are extended. So decerebrate posturing occurs in clients with damage to the upper brain stem. So when the upper brain stem is damaged, that would be presented, or patients would exemplify this position, and they will maintain or have this position. If there is a damage to the upper brain stem, to the midbrain or the pons, and it will be demonstrated clinically by arching of the back, rigid extension of the extremities, all of them, pronation of the arms, and adduction of arms with flexion of elbows, wrist, and fingers. That that will describe the decorticate, not the decerebrate. So the internal rotation, it's not the decerebrate, right? It's the decorticate. So the decerebrate, if you look at this one again, decorticate inwards, decerebrate outwards. So decerebrate outward. So back arched in both cases, lower extremities extended in both scenarios, but the decerebrate, the arms are extended, rigid, extended. So like contracted and extended. Okay, number 22. So patient receiving van-assisted mode ventilation begins to experience cluster breathing after recent intracranial occipital bleeding. So there's a TBI, traumatic brain injury. The nurse should. You will definitely notify the PCP because the cluster breathing consists of clusters of irregular breaths followed by a period of apnea. So a lesion on the upper medulla or lower pons is usually the cause of cluster breathing because the client has bleed in the occipital loop, which is just superior and posterior to the pons and medulla. Clinical manifestations that indicate a new lesion are monitored very closely in case another bleeding occurs. So you will notify the PCP so that the treatment can begin, before respiration cease, before patients stop breathing. So 23, in planning the care for a client who has a posterior fossa, which is intratentorial, because in the book you'll find about the two different types of supratentorial and infratentorial, which has to do with the posterior fossa, is that's above or lower it, but it's a type of a craniotomy surgery. Which of the following is contraindicated when positioning the client?
1.
Keeping the client flat on one side or the other. Contraindicated.
Is it 3?
I think it's 2.
This is a posterior fossa. It's the intratentorial. For infratentorial, I want to read about this in the book really carefully because that's it's an infratentorial, which is below the fossa. So it's contraindicated for infratentorial craniotomy to elevate the head of the bed to 30 degrees because it could cause herniation of the brain down onto the brain stem and spinal cord, resulting in sudden death. So elevation of head of bed post infratentorial craniotomy should be contraindicated because the elevation of the bed for the specific case is going to cause herniation of the brain down onto the herniation of the brain down onto the brain stem and spinal cord, resulting in sudden death. So the elevation of the bed to 30 degrees with the head turned to the side opposite the incision, if not contraindicated by the increased ICP, it's used for supratentorial craniotomy. So the number 1 is okay. That's good for the supratentorial, not the infratentorial. Turning like log rolling or turning as a unit. When turning, we know when we can use this, right? An emergency patient with spinal cord injury, so we can, we would avoid further damage to the spinal cord. That's when we do number 3. So any question about this question about 23? Any confusion or?
What is the best position to keep the patient in then?
For 23?
Mm-hmm.
Yeah, number 2.
Okay.
I'm sorry. Yeah. That's contraindicated, right? So contraindicated. So patients, because it said number 1, keep the patient flat on one side or the other, but it's slightly elevated. It's like slightly elevated head of bed, not 30 degrees. Slight elevation, just to maintain patient's airway pains. So number 24, the nurses caring for a client with increased ICP. Which of the following assessment findings should the nurse immediately report? And which is actually, and this sign is it's like an ominous sign of increased ICP. Once the patient with this manifestation, it would indicate the impending herniation and increased ICP and impending herniation, and should be reported immediately to the PCP.
Is it 4?
Absence of the pupillary response, like absence of pupil response. So the absence of pupil responses is an ominous sign, may indicate impending herniation, and should be reported immediately to the PCP. Fever is a common complication following an injury to the brain and should also be reported, but absence of pupillary response is the priority for this patient. Headache and nausea are also clinical manifestations of patients with increased ICP, but they may experience these signs, which is headache and nausea. But the emergency, in an emergency like situation like this, we will go with number 4. Okay, I think this is the last question, right?
Yeah.